So hopefully all of you listened to the lecture and have ideas about what we're going to do today. But before you put somebody on mechanical traction, there are 3 things you need to do. Number 1 is clear them with contraindications, right? We want to select the right people for mechanical traction. Not everybody is the right candidate. So there are general contraindications for lumbar and cervical spine, and there are some specific contraindications to lumbar and cervical spine. Okay? For example, for cervical spine, specific contraindication would be to clear them with 5 Ds for vertebral artery. You guys remember that? Okay. For lumbar spine, it would be Cauda-Equina syndrome. You want to clear them that. Somebody who has Cauda-Equina syndrome, obviously they're not candidates for mechanical traction. So that's the first thing you need to do. Secondly, you need to check the integrity of the ligaments. And we have not covered cervical spine yet, so you don't know which ligaments to clear. You don't need to worry about it. You just need to say that I will test the cervical spine disease prior to putting somebody on the traction. For lumbar spine, you will perform the anterior shear test prior to putting somebody on the traction. That will tell you if somebody's ligaments are compromised, or if they have spondylosis pieces. So those are not good candidates for mechanical traction. And number 3 is that you will always do manual therapy first, manual traction first. And you will determine from your manual traction whether somebody can tolerate mechanical traction and was it beneficial for them. So if it was not beneficial for them, then no need to go through all this and put somebody on mechanical traction. Okay. So those are the 3 things to keep in mind. Okay. I'm going to show you lumbar spine traction first because it takes so much time. So we'll go through this. Let me show you a couple more things here before I put somebody on the traction table here. So I'm not sure if it was very clear from the lecture, the placement of the pelvic belt and the angle of the pull. So we have LE1, LE2 here. And if you look at their belt, these belts are threaded differently such that both of them, if we were to do a lumbar traction in supine position for them, that LE number 1 will have an anterior pull, and LE number 2 will have a posterior pull. So I'm going to have you come on over towards me, LE, for a second. You see how the larger part of the pads are in the back here compared to the front part of the pads? And so wherever this larger part of the belts happen to be, whether it's in the posterior direction or the anterior direction, are going to provide the most pull. And they're going to provide the pull in that direction. That make sense? Okay. So in her case, it's a posteriorly directed pull. In her case, it's an anteriorly directed pull. So that's one thing to keep in mind. The other thing is, you can also determine if you want to provide traction in supine or prone. Right? And that's primarily based on what patient's comfort level is. Most people are okay with supine, but there are those who like prone, especially if they show that they are more biased towards that extension and they like extension treatment, then you would consider putting somebody on the prone position. So if I were to put this LE in supine position, just imagine her supine, and the traction pull is coming posteriorly, that's more of a posterior pull, right? Okay. If I were to put this LE in supine position, and let's say both of them have a same angle, the hip angle, she's going to get anterior pull, right? If I put her in prone position, the buckles are always going to be on the top, facing the ceiling. You never lie down on the buckles. So now if she's going to, if I want to put her in a prone position, I'm going to turn it around, right? Because she can't lay on buckles. So this part is going to go in the front now, and so she's going to get anterior pull. So the same belt that's threaded this way, in supine is going to give her posterior pull, in prone is going to give her anterior pull. Right? Okay. Likewise here, she's going to get anterior pull in supine because the wider parts are close together in the front. But if I put her in a prone position, now I got to switch it around because I cannot have her lay on this buckles. So is it loose enough that you can switch around? Thank you. And now imagine her in prone position. Okay. Now she's going to get pulled right here because the wider part of the pads are in the back. Now this is going to give her what? Posterior. So there are all these things to think through it, but I think if you kind of think about it, it's not that hard. You can figure it out. Okay? All right. So you can go and have a seat, Ellie. I'm going to use this Ellie to show you the rest of steps. So what's the next thing on my handout here? We already talked about drive, manual traction first. Determine the force. So how much force are we going to put on? You guys remember from the presentation? To start out 20 to 25%. Okay, and how much force do you need to cause the separation? About 50% of the patient's body weight. So what's 20 to 25% of the body weight? Is it okay?
140, 40% of that.
Okay, so let's say 75. She will find with 40 pounds. Okay, it's a rough estimate, nothing seriously. So we're going to put 40 pounds weight on the traction on day 1. Of course, I have already done manual traction on her and determined that she can tolerate it and it is beneficial for her. Okay. The duration, how long are we going to do it? Any thoughts from the presentation? 3 to 5 minutes to start out with, right? Okay. Especially if it's day 1 treatment, we want to start out with 3 to 5 minutes, see how well they do it. Okay, and if they do fine, when they come next time, then it would be safe to increase their body or traction weight to 50% of their body weight, right? Because you need that much force to cause the separation. If you have less than that, it may not be as effective, but we have to determine, make sure that she doesn't have any contraindication or adverse effect. So the second visit, I will move it up to 50% of her body weight, and you can go up to like 5 to 10 minutes. I hardly ever do traction on somebody more than 10 minutes. I mean, there are those people who love traction, believe me. And if they are right candidates, that's fine. They can lay there for longer. But I'm not sure if we need to really apply that strong pull for a really, really long time. 10 minutes is good. Static versus intermittent. There are no clear guidelines about that, right? But I provided you some information. So when would you consider applying static versus intermittent? And those are just my guidelines. You guys may hear it differently.
When they're pretty irritable.
Yeah. Then which one do we select? Static or intermittent?
Static.
Static, right? Yeah. So acute condition, irritable, static is good just because that intermittent on and off may tend to irritate the symptoms more. That's the only rationale. If this is a chronic condition, then of course it also depends on what's your overall goal and what's the optimal stimulus for a tissue that you are after, then you can determine intermittent. Okay. Patient position. Bless you. So now we're going to put Ellie on this table here, and you can place these harnesses on your patient either in standing or in supine. What I found is that the pelvic belt, you place it in standing, and the thoracic belt, you place it in supine. That's much easier. Okay. So now I'm going to have Ellie lie down. So let me show one more thing here. And I don't know if you guys have noticed that this table splits. You guys ever notice it? Okay. So this is only this traction table splits. You want to make sure that it's locked. It's not open before you put your patient on it. And have them lay down such that the top of the pelvic belt is right at the level of the split. And where do you put this, how high you put it, is usually at the level that you are trying to cause traction, just under that line. Okay? So it's just above her iliac crest. And so I'm going to have to lie down now so the top of the pelvic belt is just at that level. Okay. Split up. Keep coming up. More. Let's go down a little bit. Okay, that's good. Can you bend your knees and bridge a little bit? Okay.
Oh, okay.
Okay, that's good right there. So obviously she doesn't have any problem, but the patient it would be hard for them to move around that much. So now we want to go ahead and put a towel roll. This might be too big, under buckles, because we need to tighten it. And at this point, it's okay to go ahead and undo the buckles. And you need to tighten them. You're fine. This needs to be tightened more. And I realized after I putting these belts on her that this is probably too big for her. We do have different size here for people like Ellie's size. So this is for small people, okay? Hopefully we will be able to tighten it because this seems to be.
It feels pretty tight.
Does it? It needs to be like really tight, because as soon as we apply traction, if it's not tight enough, it's just going to slide out. So let's put this on under. The other thing that I didn't explain really well, if your goal is to get that posterior pull, you see the wider parts of the pads were pretty close together, overlapping, and that's how they need to be. For the thoracic belt, should be overlapping the pelvic belt, but its position is more inferior and lateral part of the rib cage, because the thoracic belt, the purpose is going to hold her upper body in place while she gets traction with her lower body through the pelvic belt. So if it's too high, it's not going to be helpful. So that's why you want to make sure that it's kind of on the lateral rib cage side. And I need another towel